And I'm very happy to introduce Professor Ross Quinlivan, who really is playing a leading role since, well, I don't know how many years, but to improve the adult care in Duchenne. And I must say, this is all in line with what we as World Duchenne Organization, when we started as UPPMD years ago, almost 20 years ago, we said there's a compelling need to ensure that wherever they are in the world, everyone diagnosed with Duchenne and Becker muscular dystrophy can benefit from a standard of care that is informed by the best practice of the best clinicians from all over the world. And it's equally important that the information available to parents and patients is contemporary, truthful, and is based upon the latest research. Well, that's exactly what you have been doing with your document. So the floor is yours. Thank you again.
Thank you very much, Elizabeth. And thank you, Susie-Anne, as well, both of you, for your help and support and for inviting me to speak at today's conference. I'm just going to share my screen, and I'm just looking for my talk, which had been there earlier, but has now disappeared. Let's put it on there and share. Yes, there we are. So thank you very much. So I'm going to talk about the consensus guidelines that we've developed for the standard of care for adults with Duchenne muscular dystrophy. These are my disclosures. And you may ask the question, why do we need an international standard of care specifically for adults? Well, I guess in a way, Elizabeth has already answered that question with her survey. You know, the standards of care that are already published are absolutely excellent. And they put the patient at the center, and they talk about multidisciplinary care with many, many specialists, but they focus predominantly on pediatric management. And when people come into the adult services, their healthcare does become more complex. And so we felt that we needed to develop something in addition to the pediatric standards of care that already exist. We're seeing really quite a different population of adults now coming to our Duchenne clinic. So my own service now has almost 160 adult patients in it, ranging from 17 to now 42 years of age. We see patients who are treated with steroids, and those people, we see some of them are still ambulant, still able to walk independently. And if they're not able to walk, the majority of people have very good arm function and sitting balance. And at the time they come to the adult services, a lot of our patients are not yet needing home ventilation, but they are on steroids, a lot of them, and need management for steroid complications. We're also looking after people who've never, ever had steroids, who require non-invasive ventilation, and who are now getting older and developing increasingly complex medical issues and becoming more frail. So the other difference between adult care and the pediatric standards of care that are already out there is that there's an emphasis on self-management and shared decision-making. And the emphasis also changes from the prevention of complications occurring to actually the treatment of complications when they occur. Adult services are organized differently from children's services, and quite often coordination and communication between the specialists can be lacking. And this can be a problem when it comes to the complex care of looking after adults with Duchenne. And as you've already heard from Elizabeth's survey, there are many adult physicians who have much less experience in managing Duchenne, but who will see you at some point during your lifetime. These may include emergency care doctors, gastroenterologists, kidney specialists, endocrine and bone specialists, surgeons, urologists, and anaesthetists. And the other problem we know is that there's very little natural history data available for adults, and there's been very little research on the management of adults. And because of this, there's also been very few clinical trials for adults with Duchenne. So if you like, the standard of care that we've developed is really just a beginning to try and get everybody on the same footing so that then we can do more research to see if we can improve this management further. And by collecting natural history data, that's going to help with outcomes for clinical trials. So in the UK, and I think the same has happened in other countries, we have developed a multidisciplinary network of doctors and allied health professionals involved in the care of adults with Duchenne. So there are 25 centres now caring for adults with Duchenne in the UK. And we've worked out they see about nearly 850 adults. And the aim of this network is to improve and standardise care across the United Kingdom. And so as part of that, we developed our care management guidelines. We also have developed a long-term natural history database, which is very secure, but this will help us audit our standards of care against outcomes and help us to identify any regional variation in outcomes. And it will help us to acquire important data to inform clinical trial design in the future. And also, we're hoping it will demonstrate areas where further research is needed. And I'm very grateful to Muscular Dystrophy UK for funding this research. So how did we develop our standard of care? Well, this is a consensus standard of care because there isn't much in the way of publications out there. So we had to go on expert opinion. So we invited the clinicians to join the network. We then had a meeting to identify the need to develop the care guidance. We then had a service user workshop. This is patients and their families and carers to try and identify what their priorities were. We then had to synthesize all the evidence that was available and reach a consensus. And this was done through a series of small and larger group workshops. These created reports, and those reports were then collated into one final report that has been peer reviewed. And I'm pleased to say this is now published in the Journal of Neuromuscular Diseases, which you can download yourself as it's free open access. So as I've already mentioned, these standards of care that we have produced do not replace the international standards of care, but they're there to supplement the care of the adult with Duchenne dystrophy. So they are more complex, they are more, if you like, detailed in certain areas. We've also developed a therapy standard of care guideline and a manual, which has also been published in the Journal of Neuromuscular Disorders. So these are the topics that we cover, and I shall just briefly go through them, not in detail, because I know you've got some more detailed talks coming after me. So the first part of the manuscript is about respiratory care, how often and when to monitor, and very importantly, when to start home ventilation. We also talk about methods to improve cough efficiency. So it's not necessarily just a cough assist device, but for example, a lung recruitment bag, which is shown here, and also the use of suction machines. We talk about medication for secretion management. And there's a section on intensive care management and how to wean a patient off a ventilator when they are admitted with another acute illness, for example. We have a section on anesthesia. Remember, there are different types of anesthetics. There is a local anesthesia, which is quite safe to give to people with Duchenne dystrophy. There is procedural sedation, where you are given something to make you sleepy, and this does require perhaps some additional monitoring, particularly of the airway, and then general anesthesia, which carries more risks. So it's very important that before any general anesthetic, there's a careful pre-assessment involving the breathing, the heart, and from the neuromuscular teams. There needs to be an assessment of mouth opening, airway management, and some people, if they're not already on non-invasive ventilation, may need to start non-invasive ventilation before an anesthetic. And we also talk about tracheostomies. And certain drugs must be avoided, and it's also best to avoid prolonged fasting. But the bottom line is, if you need a general anaesthetic, it is best that this is done in a centre that knows how to manage people with Duchenne dystrophy and not in a small local hospital. And there should always be an intensive care unit on site. You're going to hear more about cardiac care, so I won't go into this in detail, but again, there's a big section in our guideline on cardiac care. As I've mentioned, the emphasis now is more on treatment to control heart failure and rhythm disorders. And also, it's very important for you to be aware that optimizing ventilation, that's using the BiPAP machine, is very good for the heart. So it's important that this is managed appropriately as well. Sometimes people who are on heart medication can have problems with their kidneys, and we have certainly seen this in our service. So regular blood tests to monitor kidney function are very important. But why do we get these problems with kidney function? Well, it's likely that people who are on these medications don't take in enough fluid. And we're seeing in about 10 to 15% of our patients now kidney stones, which are also related to poor fluid intake. So it's really important you try and drink as much as you can. 2 to 3 litres a day is what's recommended. Sometimes the heart medication can cause low blood pressure, and that needs to be monitored. But if it's too high due to steroid treatment, again, that can affect kidney function. And finally, if we ask our patients, we find out that they do indeed have bladder symptoms quite often. The need to open the bladder urgently, sometimes some dribbling incontinence. Don't be afraid to talk to your doctor about these, because there may be treatments that you could try that would improve those symptoms. But we do know that more research is needed in this area. Nutrition
part. So I wanted to present that case, and just a
nutrition and bowel is very important that we see in our adult patients, particularly preventing weight loss. Obesity is less of a problem. And when people have a very severe weight loss, we have to be careful when we build up their weight that they don't develop something called refeeding syndrome. So this needs to be done quite slowly over several weeks, carefully with a speech and language therapist. We talk about gastrostomies and jejunostomies, the management of constipation, abdominal bloating, and other abdominal issues. And these can be helped with venting through the PEG, for example, but a lot more research is needed in this area. In terms of endocrine and bone, there's nothing much that's very new. This is mainly taken from the International Standards of Care and a number of ENMC workshops. But don't forget, if you're on steroid treatment, don't suddenly stop taking your steroids, and you need an emergency plan so that if you become unwell, you know how to increase the dose. If you're on steroids, it's very important that you have regular bone protection and assessments. And finally, these are new things, glucose intolerance and ketoacidosis, which we see sometimes in older people with Duchenne who become unwell. Participation is a really important and key aspect of the care of an adult with Duchenne, as is psychosocial care and also palliative care. Transition is really important. This is the preparation for becoming an adult, and this needs to start really early in the early teenage years. And it's a very good idea to have joint adult and pediatric clinics. There should be a full range of therapy services available to the adult with Duchenne, which quite often there isn't. And a clinical psychologist should be embedded within the neuromuscular team, as should a palliative care physician. Now, I know the word palliative care often creates a lot of antibodies amongst certainly my Duchenne patients, but a palliative care physician has a lot of experience in managing a lot of the symptoms that you might experience as you get older. And they can be really, really helpful in advising us on how to manage these symptoms. So, for example, pain and fatigue. And of course, don't forget anxiety and depression. And they can offer a lot of support, as can the psychologist, to both the patient and their families. So in terms of our natural history database, we're going to be collecting standardized medical and physiotherapy assessments. We're going to be uploading that data from all of our sites with patient consent. And over time, this is going to allow us to audit this consensus care guideline that we've created so that we can fine-tune it even further. We hope this will demonstrate any regional variations. So that might help our commissioners understand that certain clinics might need more funding, for example. And also this database will be important for us, certainly in the UK, for what we call managed access agreements. This is for expensive drugs. So for example, Ataluren. And it's going to provide essential data to inform clinical trial design. And I know other countries are going down this road as well. And I think it's a really good idea to start including adults in these longitudinal databases. So I'm coming to the end of my presentation. I'd just like to thank Muscular Dystrophy UK for funding and supporting this work. I'd like to thank all the members of the Adult North Star Network, our user group, and we had lay experts who advised and peer reviewed the documents, particularly our standards of care documents. I'd like to give a huge thank you to Elizabeth, because she was really quite instrumental in helping us get this work published and for allowing us to disseminate it through the World Duchenne organization. So thank you very much, and I'll hand back to Elizabeth.